Kobeiter with visceral aneurysm. Hicham Kobeiter is the head of Henri Mondor Hospital, which is one of the biggest university center in Paris.
Good morning again. Thanks for the invitation, and I'm really happy to be here with my friends in Egypt, almost feeling like home. So I'm going to talk visceral aneurysms. Okay, so visceral aneurysms are not very, very common, and you need to have to differentiate between real aneurysms and pseudo aneurysms. My talk is going to be more about real aneurysms and when they rupture. So the distribution is commonly they are mainly on the splenic aneurysms, but other location also could be found. Celiac trunk, hepatic, and especially the duodenal pancreatic, all the branches coming from the SMA. To go quickly on diagnostic, CT is the main diagnostic technique. You could not treat a patient nowadays without having a good CTA. It will give you the diagnostics, anatomy, and the difficulty and all the variant anatomies that you could encounter during your treatment. And you need to know how to reconstruct all the images to make your life easy during the intervention. So in non-ruptured aneurysms, there's some recommendations, especially there's a new recommendation from the Vascular Society of Surgery showing that for pseudoaneurysms, all sizes should be treated, whatever size doesn't matter. We should treat, whenever you have a false aneurysm, you should treat them because those lesions will rupture and have a high risk of rupture. For the other, we're going to see the most common of them in more details. And if you look at the technique to treat those aneurysms, you have different scenarios. You have the saxiform with a small neck. Normally, it's easy to pack, like neuroradiology, or you could treat them also percutaneously or put a stent grafts. It's not very common to put a cover stent in those lesions because sometimes they're very tortuous. If you have any large neck, you could go and put also stent graft, but also need some other technique like assisted coiling with stents. If it's a fusiform, if you could sacrifice the vessels, it's easy to go and most of the time to the back door, the aneurysm, and the front door to close the aneurysm, or to put a stent graft is feasible. If you go to more complex with different collaterals, you should occlude collaterals before treating the aneurysms. So when you can sacrifice the vessels, if you have an emergency life-saving, sometimes you're going to see some cases, sometimes you need to sacrifice even a renal artery. But in the majority of the case, if you go to the main trunk of the spleen, you could sacrifice it. The GDA, a lot of collaterals, and renal, if it's distal or a distal force aneurysm, sometimes you need to sacrifice. So for the splenic, mainly it's women, 4 more times women than men. Normally you should treat the aneurysm is above 3 centimeters. And in women, whatever, a woman, if there's a childbearing age, or if there's any other comorbidity like a portal vein hypertension or other vascular wall disease like Ehlers-Danlos or other type of disease. Here we're going to see one case. I'm going to try to go fast if I can. I cannot have the... I don't know if we can go fast. Normally we could... Normally I can deal with the images. No, it doesn't matter. Okay. No. I was able to see the toolbar. No. It's impossible to have the toolbar to move the movie. Okay. doesn't matter. So let's go to so sometimes it's more difficult to assess if you have this patient have a liver transplant, ligation of the splenic artery, and with a lot of torture. So we need to go through the collaterals to do the embolization. I don't know if it's working, the movies. No, the movies are not working. I don't know. No, this doesn't matter. Okay, so let's guess. We're gonna see other cases a little bit later. So for renal, it's not very common in series, and rupture is very, very uncommon. Rupture rate, it goes from 0 to 14%, and normally is a size to be treated if they are not ruptured as above 3 centimeters, and also if you have it's a woman with a child burning age, and also if you have a refractory hypertension or renal artery stenosis. So here's some cases. This patient have no trauma. He came with abdominal pain and back pain. Find a kind of intraparenchymal aneurysm. There's no puncture, nothing. So we don't know. It's like a old trauma, but it's kind of false aneurysm on a very distal vessel. You could also use 3D imaging to depict which vessel is going. Sometimes it's not easy to see it on DSA. So we went selectively to and sacrifice this vessel to include this large aneurysm of us 3 centimeter. Packing, and when you cannot sacrifice, you could do packing, especially if you have a small neck. You could use different type of embolic material. Like here we have this patient having hypertension and having this aneurysm that was a little bit growing during follow-up, and we wanted to treat it selectively without sacrificing any vessel. We put 2 guide wire, go into the aneurysm, pack coils, and during follow-up, this aneurysm is totally excluded, and here we have the control on the angiogram with excluded aneurysm. Sometimes if you have a large neck, you need to do an assisted coil embolization, like in this case, this patient was 56 years old, have back pain, also considered as a symptomatic aneurysm. So we decided to put a flow diverter stent into this aneurysm because we have this large collateral right here. We can see the angiogram here, and we see this is very large collaterals going out. We did put a flow diverter, and 2 months after, patient still have her back pain, and the aneurysm was still patent. And even the flow was a little bit slow, so we decided to add some coil embolization in this patient. Normally should. And so we did it cross through the stent. Normally it's not supposed to be able to cross through the stent, but crossed and put a small microcatheter, and we packed coil, and here's a final control showing that we did keep these collaterals and embolize the main part of the aneurysm, so this patient didn't have any more pain. So if you go to the SMA branches, they are the most dangerous one, and they should be treated whatever size. It is mainly it's done because when you have a high flow into the aneurysm. So this patient came with pain, abdominal pain. We discovered there's 2 aneurysms, and they were embolized selectively. This one have a large collateral going out, embolized and packed coil. The other one was a large artery. We did embolize. We always worried about it had not enough blood supply to the celiac trunk, but we have published our series about more than 13 patients. We don't have any ischemia when we embolize, or even those very large collaterals. When we go to ruptures, why do we need to do them by endovascular treatment? Because in the studies that we conducted with St. Mary's Hospital in the UK, we have shown that the mortality of endovascular treatment of ruptured aneurysm is way less, significantly less than when they are treated surgically. So normally, if you can do endovascular, it should be done endovascularly. So there's another case when we need to sacrifice the vessel because it's impossible to do in another way. A very large renal aneurysm, 8 centimeter, ruptured, patient unstable, and impossible to cross with a guide wire. Blood pressure was crashing, so we decided to exclude to the artery with vascular plugs. We did put 2 vascular plugs inside the artery, and here's the control with a totally excluded aneurysms. Another case of a duodenal-pancreatic aneurysm rupture patient had surgery in the first because they didn't do any CT scan, open it, packed into the abdomen, went to CT. We did see this rupture of this aneurysm. It's not very large. Most of the time they are not very large, even they rupture, and he was treated by cold embolization. This case was done last week. It's a patient who has cirrhosis, portal hypertension. Aneurysm were known, but she was not referred to us until she ruptured, and she came in a huge hemodynamic instability. So the only way was to treat all those aneurysm, and here we see the rupture was a contrast stabilization. Were treated with glue embolization liquid because she had like a her hemostatic status was very, very bad. Sometimes it's more tricky. Patient, she was a physician with a large number of kids. She had abdominal pain, low blood pressure, sent to us, had a CT scan, almost sent to the gynecology because they suspected something in her pelvis. But when we looked at the CT scan, we see the small aneurysm of the spleen artery, and if you do a VR or reconstruction, we could see it clearly, and the hematoma was surrounding this lesion, and was treated by selective embolization with stent-assisted embolization. Stent graft, if we can, but most of the time it's very difficult to do them in emergency setting. Ovarian artery is very uncommon. Few reports, most of the time are patient with multi-delivery and surgery in the pelvis and multi-pregnancy. This patient, 47, have already 7 child, back pain, blood loss, CTA showing this very large ovarian artery with this aneurysm right here. It's the only one I have seen during my career, so I went and did the embolization, but you should keep this in mind. You need to follow those patients. The best follow-up is probably by MR, especially if you put a cause because of the artifact. If you have a stent, it's feasible by CT scan. But if you put cause, you need to have an MR during follow-up. So in conclusion, it's really important to have a CTA to plan and to size all the material you need to do on the vascular treatment, especially in ruptured aneurysm. In emergency setting, is the treatment to go, and you have different options depending on if you can save the artery, if you can need to have a patent artery, or we can sacrifice the artery. And follow-up should be, because you can have recurrency, should be done and optimally by using MR. Thank you.
Thank you, Dr. Hicham. But I have a question, please. After, okay. So next speaker, Dr. Sameh Sabr, he will present.